I want to welcome those that have signed on. We'll give everyone just 30 seconds or so to get to join, and then we'll start the discussion. Thanks. Given we have a lot to cover, I think we'll get started this afternoon. I'm Ferris Taylor, and I want to thank everyone for joining. I see the numbers going up quite rapidly, and that's okay. But Charles Steller and I want to welcome you. I'm Ferris Taylor, the Executive Director of the Healthcare Executive Group, and Charles, do you want to introduce yourself? Let people get used to your voice. You're on mute, Charles.
That's what my voice sounds like. My apologies today with my challenged voice, but I wanted to also add my welcome. I'm the President and CEO of WEDI. And it's indeed a pleasure to be joining HCEG, Ferris, and Eric and other colleagues, and certainly today's production. You will be meeting Chris in a few minutes, but the folks behind the scene, I want to recognize Steve and Michael, Steve from HCEG and Michael from WEDI, on making everything work. So thank you in advance.
And I echo that, Charles. This effort between WEDI and HCEG has been a very good one. This is our 11th annual Industry Pulse. Prior Industry Pulses have been vendor sponsored with HCEG, and Charles and I have relationships going back, I guess it's close to decades, Charles, and we put our heads together and felt like it would be great to put two organizations together behind taking a pulse of the industry. And Michael, Charles has introduced everyone on the next slide, but just so you have names and titles that are there, Charles and myself, let's hear a few minutes in just a minute from Nancy and Eric and Rob and Chris. But a couple of housekeeping details in the next slide before we go on. We will be taking questions. We want to engage all of you in the discussions that we'll be having today. So use the chat function to put in comments. We'll also have a couple of polls, and in chat, if there's some reason to have one of you get involved in the discussion, Michael, behind that WEDI logo on the right-hand side will be able to unmute you. But we hope that between chat and the discussion and the polls, that we'll be able to have a great conversation. So Nancy, why don't you introduce yourself and tell us a bit about WEDI, and then Eric can do the same.
Sure. I am Nancy Spector. I work with the AMA, American Medical Association. I've been on the WEDI board for quite a number of years, and I am serving now as the board, the chair of the board. And so I'm happy to be here today talking about WEDI and the joint work that we are doing here with HCEG. For those of you who don't know about WEDI, this is a little bit of background information. WEDI was formed in 1991 by then Secretary of HHS, Dr. Louis Sullivan, and WEDI is named in HIPAA as an advisor to the secretary. And so we work closely with the administration, have worked closely since 1991 with CMS and other partners or agencies within HHS, Office of Civil Rights, Office of the National Coordinator, just to name a couple of those. And I always like to talk about WEDI in terms of its mission, which is really to be an industry convener and to provide multi-stakeholder leadership and guidance on how to use and leverage technology to improve the efficiency and quality and cost effectiveness of health information. So I will leave it at that, and I will turn it over to Eric.
Thank you, Nancy. My name is Eric Decker. I'm the Chief Information Officer for Independent Health, Regional Health Plan in Buffalo, New York. And I'm also the Board Chair for Healthcare Executive Group. Just a brief overview of Healthcare Executive Group. We are a network of healthcare executives who collaborate with one another in more intimate settings like this very collaboration with WEDI and discussions related to it, like this webinar. We discuss many industry priorities, issues that change and evolve every year, really in an effort to allow our members to customize the dialogue as their operational and strategic priorities shift in response to changing market dynamics and legislation and regulations, which is what is a result of our annual HCEG Top 10 and Industry Pulse research. We are not a conference, but rather, again, I reiterate, a network where we exchange ideas. And we do find that healthcare executives trust their peers more than any other source when facing industry priorities, issues, and challenges. And we thank you for being here today.
Thank you, Eric, and thank you, Nancy, for your involvement with us in this first year of working together on Industry Pulse. And as Eric said, one of the things that I think both Charles and I appreciate is that our board of directors really drive the programs, the work groups that WEDI is working on and what HCEG is involved in. So with that, Michael, let's jump into sort of our agenda today, and we're gonna have kind of two parts. First of all, this is the announcement of the formal results, the final results of the Industry Pulse survey. And it's kind of a 6-month process. It begins with the HCEG members, health plans like Eric's, primarily regional state-based health plans, voting each year, and we've done this for 15 years or so, an HCEG Top 10, modeled after David Letterman. And you see here the 2022 HCEG Top 10. Michael will put a poll out that you can respond to as to what's missing on the top 10. We start with a list of 30 or 40 issues, and our members vote those. But because we recognize that we're just a small segment of healthcare, WEDI and HCEG went out to our membership and to the industry at large with our 11th annual Industry Pulse. Two purposes: validate the top 10, but dig deeper in some of those. And you'll see arrows to the left of, or to the right of the top 10 on 4 of those that we're going to talk about in a lot of detail today. But before we get there, I'm going to ask Chris to actually go through the results of the HCEG, of the Industry Pulse survey. And we'll post in chat a handout, which has all of the data in it. So don't worry if Chris is going through quickly in the data. You can click on the handout in chat and be able to go back and look at that data. We will be asking you, as soon as Chris reviews the data, to actually join us in a discussion of the meaning of some of these results and what impact they'll have on healthcare in the future. So feel free to vote on what we missed in the top 10 while Chris takes us through the data. And I'll let you explain the survey and the demographics, Chris, that's shown on this slide.
Yeah, thanks, Ferris. So yeah, we are going to dive into what is a lot of the findings of the industry polls. I'll emphasize, we are going to move through what we're talking about today pretty quickly. Ferris referenced that documents, and it looks like Michael just shared it in chat. So really encourage you to pop that open and have it on the side just so you can look at it, reference back to it. But I'll also say before I dive in that this isn't the totality of the findings and analysis. That's going to come down the road a little bit. Ferris, Steve, and I are kind of working on that behind the scenes. But we really wanted to give everyone here a little bit of an overview and feel for the data before we actually dove into the discussion. Just give everyone a bit of a common foundation to see where we're coming from. So with that, I will mention the demographics a little bit. So I don't think we have a dedicated slide for the demographics, but if you do have the report, you can kind of see in the corner, we really wanted this industry pulse to talk to the whole healthcare industry. Historically, the pulse has gone after the health plans of the world, but that wasn't the full conversation. And so using the pandemic as almost a reset point in a lot of ways for the survey, we wanted to bring in the voice of the hospitals, the providers, vendors, and really get a fuller perspective. So this is the 11th annual industry pulse, but it also is a relaunch, a revitalization. So it's really exciting to share with you because I'm hoping as we get going with this, we get more excitement out of the industry and we can keep growing this and just seeing more and more success. And so that's a respondent type. And then levels, we've always gone after senior leaders just to get their strategic perspectives. You can see a little bit, it really is the C-suite, the president's vice president that make up the majority of a response across all respondent types, whether they be a payer, provider, vendor. But we do capture a little bit of everything out there. So we do have directors and managers and just kind of individual contributors. So a little bit of everything, but focusing on leadership and those folks. I think so with that, we can move forward into the actual data. We can skip this or go right in. I'm going to try to go through fairly quickly. So one of our big topics was price transparency. And so you can see what we wanted to understand is what the general view is on the impact of price transparency and how that'll affect overall costs. And what was interesting is how mixed things were, looking at the payers versus the providers versus everybody else. Payers leaning a little bit towards saying prices might increase due to transparency, providers thinking that it really may have no impact. So we saw really a lot of uncertainty, some lack of alignment across the market on this. And I do think in some cases, this is a nice setup slide because it plays out in such a way to say, okay, well, we know we need to move in a certain direction, whether it be a health plan, whether it be a hospital, a doctor's office, surgery center, what have you. But we may have some very different perspectives on necessarily how to get there in the best way, or we have different motivators and drivers. I think you'll see that consistently throughout the data. So if we look forward to the next question, we go a little bit further into what the practical effects of price transparency will be. So cutting down one layer. So here we're breaking out, and you'll see this pretty commonly. We have payers in green, providers in the yellow, and then the all respondents. This is payers, providers, vendors, everybody represented by that white line. You can see there's actually a lot of agreement here at the top end, and that falls off. So a lot of feelings that we'll see some more shopping, that we'll see more awareness of price comparison tools. But then, as you go down, you start seeing maybe some things that are different, where you have payers who really think that the price transparency is going to lead to a decreased impact of out-of-network providers. A very different perspective from our provider respondents on that, which is quite interesting. But other than that, you do see a lot of agreements on some of those big topics. So I think we have one more, yeah. And then, so we kind of went a level further on the next slide to see, and this is saying, hey, put yourself in the shoes of the consumer. How do you think they're actually going to use pricing information that's going to become available, whether it be through no surprises or through voluntary processes? And again, we saw a lot more variability here around those expectations. So providers really thinking that they're going to look for those best fit physicians. They're going to look for physicians that offered lower costs. So that's pretty common. Whereas you have a little bit more uncertainty, a little bit more skepticism maybe on the payer side around whether or not consumers will use those prices, whether they may start deferring care a little bit. So this is where you start seeing a little bit more of that uncertainty I'd mentioned earlier from the payers and provider side of things. Though I will say one thing's interesting, if you look at that all responders line for the first two options, the vendor responders really, you can get a sense for favorite lower cost providers are much more skeptical there. As you can see, that all responders line is even short of the payers. That means the vendors are probably even further in being skeptical about favoring low cost providers, whereas they really do think there will be more shopping. As coming from the vendor side myself in all of this, if I were selling a solution that gave access to consumers to shop for care, yeah, I might really think that's a thing that'll happen. So this is, again, an area you're really seeing perspective in a big way, and motivators coming into play. So then on the next data point, we're still talking about consumer-centric strategy. So this is actually a carryover from 2019. So the last sort of pre-pandemic version of the industry pulse, where the same question was asked. So we didn't change this question at all. We asked in 2019, we asked it again in 2022, what your consumer-centric strategy looked like. And I will add in that each of these strategy, nascent, intermediate, full strategy, they had full explanations within the context of the question. So there was some detailed information about what it actually means to be intermediate on the scale. So there was some good context for the respondents. So we saw what I really think we see here is just a pause or a slowdown due to the pandemic. I don't think this is a trend. The shift to consumers in healthcare is going to slow down. But certainly the last couple of years have just had different priorities. And I think that makes sense. So seeing that providers are still kind of split 50-50 on this, it makes sense to some degree. It's just shifting priorities due to the shifting environment. And I would expect in 2023, 2024 to start seeing a trend towards more complex consumer-centric strategies. Another area that we really wanted to explore, and so we see this on the next slide, is healthcare accessibility. So this is the extent of just going a little bit further down the path. And we looked at both some of the barriers, and then in a minute or two, we'll look at some of the ways we can overcome accessibility. And again, you see providers and payers have a little bit of difference here. But I think one of the biggest call outs and differences here is, providers really are concerned that reimbursement is going to be an issue. So I'll call out when we say provider reimbursement versus reimbursement for telemedicine, virtual care. So the full kind of explanation there is provider reimbursement refers to kind of any new care pathway that is happening in person. So it could be more home visits. It could be a number of other care pathways, whereas the other one is specifically telemedicine, virtual care. So providers are really concerned about getting compensated for that work, and do see that as if we are not getting compensated, how are we supposed to provide that care? It doesn't keep the hospital solvent, it doesn't keep my practice solvent. So that's a big barrier that has to be addressed when new innovation is coming along, and we need to say, well, how are we going to actually reimburse physicians for the work they're doing? So that's really a big concern, as well as just having the technology investment necessary. We can see with that first option to support those things, and that's a concern for the payers and the providers. And I think you see a little bit more scattering responses from the payer side around consumer willingness to use new sites of care and provider willingness. Some of those can be addressed with reimbursement plans, but it is something that is going to have to be addressed. Which, if we move on to the factors for improving healthcare accessibility on the next slide, we see some of the ways to tackle these, and provider reimbursement is obviously very popular, and reimbursement around telemedicine is where you'd expect it to be. This is the biggest differences. I got my slide, my brain out of order on that one. So this is just cutting down a little bit deeper, just to show where we have the biggest differences. So we can skip past this one because I think I covered it pretty thoroughly. So value-based payment. This is another carryover question from 2019 that we wanted to say, let's ask the exact same question, see what things have changed. And you, again, see sort of the same thing where it's a little bit scattered, and you see really some pullback from where we were in 2019. I mean, this is likely, again, due to pandemic effects. A lot of the care that hospitals were providing, you had lost care, you had a lot of care that was, again, more focused on fee-for-service, built around COVID patients. So this is something that we have to watch and see what the trend evolves into. This is something I closely watch in kind of my normal day job to see how these things are trending. But it'll be really interesting, I think, to see how this shifts, because I know as an industry, we want to be moving into that value-based direction. And I think this pullback is temporary, but again, it'll be seen. I know this group will be talking about that more in just a few minutes. And so I think I've got about a few minutes. So I'm going to try and move a little bit quickly through some of these. So the next one, we look at what makes, these are some of the lack of alignment between what would make value payments successful. So you can see some of the differences here between risk sharing. This is an ongoing thing. It takes a lot to say, you should have downside risk on the provider side. It is a scary prospect. Where you use a little bit more excitement about that on the payer side. And then there is some other minor disagreements and lack of alignment around, demonstrating material savings, and also the having the benchmarking in place to make sure we're using the right value-based benchmarks to say what is really meeting the criteria or not. And then we'll look just quick at the next slide, that is where we have alignment. So I think these are really encouraging. There's a lot of agreement around sharing patient data with the providers, get the doctors the data they need to make better decisions, make better care decisions. That's fantastic. Program design, this is also encouraging. There's alignment, like, hey, we have some good programs in place. We have a lot of those tools. It's just being able to get past a lot of the pandemic focus and getting back to the job of making healthcare better and more efficient and delivering that better care. And I think this was always interesting, this one at the bottom. We've got a good number of programs. We don't need to start cleaning house. We're at a good place. We have a lot of things we need. So I find this ultimately really encouraging, even if there are some areas where alignment isn't spot on. So this next one, next we have interoperability. This is an interesting one. So we just want to get an idea of where companies, a lot of payers and providers sat in terms of interoperability. We had a third in each of these two groups tell us that they really don't know where their company's at. We provided some detailed definitions again. So when we gave them foundational, structural, we did provide some really detailed explanation of what that entails. A lot of unsure. I think this is really interesting. I think maybe because it may feel like it's a little bit on the tech side, it's a little bit maybe with the CIO and maybe the IT vertical rather than with the rest of the company, maybe your HIM director if you're at a hospital. But it does tell me that maybe within the industry, there needs to be better communication around how important interoperability is towards a lot of the goals that we have, which I know, again, is going to be one of the topics that this group will be tackling in the discussion. So next we have some barriers to interoperability. I think, again, you see some of the same things here. Closed EHR architectures being the one big area where both payers and providers agree that there's a challenge. I certainly see that with customers struggling on the hospital side to exchange data and move data between their EHR and another provider's EHR. So I know that's a real challenge. And then everything else, there are some some areas that are painful. You have organizational resistance to data sharing, having issues with multiple data types. I think a lot of these, though, are slowly getting addressed, but there will continue to be some challenges maybe around stakeholder incentives and the data exchange, especially with how instrumental and central EHRs are in the healthcare space. So now we can quickly look at how to accelerate interoperability on the next slide. We do see some big differences here in a couple areas. So, payers really, they feel like having those clear standards are key, not even halfway there with providers. But then we have our friend financial and clinical incentives popping back up with the providers. So there is, I think, a real need. And I saw this a little bit in early comments around TEFCA from some groups representing hospitals and physicians, that they felt like there needs to be some degree of, whether it be a incentive or a penalty associated with TEFCA and QHIN participation. I think that sort of is represented here in the data as well. And I think we'll just flip the last one, because I think I'm already over my time by a few seconds. So the last question we had was asking about which policies are going to be affecting healthcare the most over the next 3 years. This is just a selection, I think, of the full list. And you can really see, I think, prescription drug pricing is seen as like a hugely impactful thing. And then price transparency, the balance billing, whether it be or No Surprises Act, really things where there's a decent amount of uncertainty, especially as you can see here on the payer side. But again, I know that's an area we'll be talking a lot about. So with that, I will wrap up the data read. I'll say there's more detail in the handout we shared, and then I know Ferris, that we're going to we'll probably have some even more detailed report out down the road coming from HCEG.
Thank you, Chris. And the idea was that we would use Chris's walkthrough of all of the results that came from Industry Pulse as kind of a springboard for the next 30 minutes or more in a dialogue among the panel and with each of you. And I've been trying to keep up with comments in chat. I may not do that as we go into the discussion, but keep your comments and insights coming in chat. And also with respect to the poll that Michael had put up, don't hesitate to put into chat things from either the top 10 list or from what Chris has covered that you think need further highlight, or ask questions of us. So, with that springboard, maybe Rob, we haven't had your voice on this at this point, but any insights? What did you see? And you've had the advantage of seeing the release of the Industry Pulse data for a day or two. What jumps out at you?
Thanks, Ferris. And first of all, I think what jumps out at me is very interesting results. But I also see, not surprising, a lot of overlap between some of the issues here. And I really liked the discussion in the chat and the way that Chris brought out some of the key issues. And I'll just highlight a couple. Telehealth is clearly an important issue for all of the key stakeholders, payers, providers, but also the patients. And we're lucky we have Nancy Spector, who's chair of our telehealth work group, on the line as well. But what strikes me is you look at the issue of telehealth, and you can go down the top 10 list, and it really pings on every one of the 10. It certainly is going to impact cost. And I think one thing that I'm personally very interested in hearing, in particular from health plans, how telehealth has moved the needle in terms of cost. Because you could look at telehealth in two ways. One, that it's increasing access, increasing costs, or it's better access in particular for patients with chronic illnesses, and therefore it's keeping them out of the ER, which is overall lowering costs. So that jury is out. I think we need to see more and more data on it. But when you think of telehealth, you think of access, you think of the ability of the patient to, instead of taking a half day off of work, they can have a quick consultation with their provider. And the question is, of course, what will happen after the public health emergency is over? Is it going to go back to the old ways where telehealth really wasn't an option, or is the genie out of the bag and now it's going to be up to providers and health plans to continue to support that type of care delivery? I don't know. I don't want to put Nancy on the spot, but I know she's an expert on this. What are your thoughts, Nancy, on telehealth?
Well, first I have to start by saying I don't think I'm the expert on this, but I'm happy to share some thoughts. I do co-chair the telehealth work group, and luckily I have a great co-chair who works on this on a day-to-day basis. She's with Anthem, Jill Dominic. But I think, yes, the waivers did a lot to open up telehealth and allow for the reimbursement. And so the question, telehealth was considered to be, innovative and sort of the next wave of care delivery prior to the pandemic. And then the pandemic, blew that all, open, and it became, a necessity in order to see patients for this first few months. And so, as you said, patients have gotten used to this, providers have gotten used to this as a good care delivery method. And are people going to be willing to go back if the payment doesn't stay there? Because I hate to make it sound like it's all about payment, but there is, a cost benefit that has to be done by every organization in making a decision, any decision, but around this. And so, yeah, I think that we'll start to see maybe some of the maybe some tea leaves or whatever you want to say, reading of that, maybe with the physician fee schedule rule that will come out. The proposed rule is due out in a couple of weeks. That's usually where we've seen some of the payment information about telehealth. So that's kind of my thoughts. Others, does anybody else have thoughts around telehealth?
I think, Nancy, you hit on the reimbursement side, which showed up multiple times, as Rob said, across multiples of these questions. I mean, it is something that has changed. I actually would add to the provider side of it that you've mentioned that up until COVID, the consumer mentally may have been in that place where I can do anything I want to do. When I get sick, it's the doctor's job to make me better. And suddenly with COVID, the doctor couldn't make us better. We all then started to realize I have a role to play in my health as well. And more, digital health, remote monitoring, wellness devices, all of that kind of plays into this. But your point, I think, was critical in terms of the reimbursement. And then, of course, as you said, Rob, a lot of these topics, and I see in chat a number of others that have commented on how, cost and transparency cuts across a number of the other issues. We'll get in a minute to value-based care and transparency, but Eric, is Independent Health directly involved with telehealth?
Indirectly, and I guess I would say from it's different with our primaries versus our specialists. Our primaries are predominantly in a value-based capitated model. And, just speaking for myself here, and it helped carry the primaries through, I think, with respect to being paid monthly on the retrospective basis throughout the pandemic. But even this week, I ran into some poison ivy and just took care of that with my primary on telehealth. But to that end, I don't know, we're not there with our specialists yet, and that's still an opportunity that I know that we need to work on here in our region. I see there's maybe a few in the chat, Lindsay and Jeff. I don't know if we can take them off mute. We also have.
Will do.
Who was it, Lindsay? Something quick that you wanted to comment?
There she is. Go ahead, Lindsay.
She's still on mute. I don't know if that's your button or Michael's button. There.
Hi, can you hear me okay?
Yeah.
Yeah.
So thanks for having me. I mean, I work for the VA, so it's a little bit different of a system. All of our providers are required to be able to offer telehealth, and we offer it freely. But one of the things that I'm thinking is if we're talking about value-based care, and if we're talking about a consumer environment that it's going to continue demanding telehealth, that's something that's got to be considered as the larger community thinks about whether they're going to continue offering it. I know that the program that I came from most recently was the Caregiver Support Program. And what I mentioned in the comments is that we had a significant decrease in our no-show rate as soon as we implemented, all telehealth across the board, because when you think about a caregiver trying to get their patient into the car or the vehicle to come in when it maybe was a visit that would not require needing to be face-to-face, we immediately saw that we had just better show rates to our appointments. And so it's a mandatory option of menu items if the visit can be telehealth across the board, but we have the same RVU or the same value rate for payment. I mean, we are a single payer source, but we still receive our funding from our national, levels. And so I don't know, I think even outside of the VA, if you think of consumer driven or value based, and think of our environment, our age group, younger than me, and they want tech, if Eric mentioned getting poison ivy. I don't want to take time off work to drive in so that you can tell me I need a cream to put on it for it to go away. That's ridiculous. And so I just think I would be surprised if the community doesn't continue to say, no, I want this. And if you don't provide it, I'm going to go find somebody who I shop as a person. I shop. My first question is, can I have this telehealth, please?
So and Lindsay, Lindsay was on a panel. she's a nurse and
I'm a social worker.
Social worker. Well, she was on a panel with a strong voice as to the challenges of more integrated care, and virtual is certainly one part of that. For the panel, this topic of value-based care, and you sort of got us going that direction with telehealth, but the big topic of transitioning healthcare to a value-based system. What's holding us back? We saw a little bit of data around that, but comments, perspectives?
Yeah, perhaps I'll start. And when you think about value-based care, you think about two issues, at least I do. One is risk, because in many value-based or risk-based contracts, there is some pressure on the providers. And if they meet their objectives, there's a potential of a bonus. If they don't, there's a potential of decreased reimbursement. So there's risk involved. And so generally speaking, providers are risk adverse. And so there has to be a pathway for success. And I believe that pathway flows down the data river. The better data that the provider has, the more likely they are to succeed. And I would put telehealth directly in there, because the idea is to be able to understand, first of all, if there is an issue with a patient, either currently or in the near future, and to be able to take action to prevent a higher cost service. So I'll take an example of a diabetic. who ends up in the ER on the weekend, if that data feed can go back to the primary care early in the week, they can do a follow-up visit, whether it be face-to-face or virtual, to make sure that that diabetic patient is adhering to their meds and they don't end up back in the ER, which drives up cost and potentially would impact the risk-based contract. So I don't know if others have some thoughts on that.
Yeah, I do. I think this is the kind of thing that we just have to figure out how to make this easier. It's just too hard. It's too hard. Yep. And physicians have so much coming at them already, and they certainly don't want to take on any more risk. And I think the onus is really on the technology providers to get over their protection of their technology. And the onus is on, a lot of the health plans to just incentivize making technology easier to use so people want to use it. And I think the health plans have a lot to do with bringing in the kind of infrastructure that can really incentivize this. And so, I mean, that's where I think it has to come from.
It's Jeff. I just want to ask a question. Where is the complexity? Is it in the tools that are used for telehealth, or is it, if you'll explain that a little further, the complication?
Well, I think I think understandably, a lot of physicians have resisted. They mainly have a hate relationship with technology because it's been used to control them through billing. And so I think that's part of the problem and they tend to think that if technology is going to be, if its use is going to be brought in and its use is going to be increased, it's just going to be used to seek to control them and more micromanage how they care for their patients. And so I think a lot of it is has to do with the messaging that comes through and the things that some of the plans could do to actually show that that technology is just going to be used to help them practice at the top of their license, and it's not going to be used to further micromanage them. I mean, I think that's one of the bigger things. So you add that to the fact that a lot of these, you've got all these rules about interoperability that were supposed to apply to all the EHRs, and most of them certainly avoided it, all those rules as much as they could. And so I think the health plans themselves really have to, and they've got bright people working with them. And I think that's coming. And I certainly am trying to figure out, how to encourage more of that.
Yeah, I was, I sort of go along with Lindsay saying that, it's worked for me. And I think it's worked for all of my physicians who seem to have a seamless add-on or part of their practice management system.
Right.
And it just seems to be all around. It just seems like it's working beautifully. I certainly prefer that over spending hours getting in and out of a physician's office and possibly being exposed to other conditions.
So why do you think you're in such a minority then? If you like it and most don't or are having trouble?
I'm not. I think, at least my experience is most people, most individuals love telehealth. And I'm speaking, and I guess with the data, Ferris, does the data support that? Just to go back, that from the consumer perspective, it's a widely popular option. I think what the data was showing is there's
absolutely It is.
There's more the challenge of reimbursement and what happens, especially with Medicare and others, what happens when the funds, when the rules change. But, you know, as Lizzie said, it just seems like it's totally right for the patient.
I agree. I mean, I think it's the best thing that can happen to healthcare. And I get angry when I think about physicians that want to just refuse to go there, because it's the only way you can begin to create any sort of health equity out there, you know, in my opinion.
So, and you know, this topic is touching on something else, Jeff and Charles, that Rob and some of the WEDI work groups that I've participated in over the last year or so, and that is this big word of interoperability. And I think we would be really remorse or we would regret not talking a bit about interoperability as it relates to the whole process of healthcare and these priority issues. I know, Rob, you've commented before with me on that.
Sure. I do want to give Nancy a chance. I think Nancy, you wanted to say something.
Oh, no,
on
that's okay. I had another point I was going to raise, but let's talk about interoperability first.
Yeah, you know, there's a lot of talk in the chat, and it's clearly on the top 10 list, and it sounds absolutely wonderful. Just have all information be able to flow where it needs to go. But there are some potential drawbacks from the end user perspective. And we have to be careful that we're not giving providers too much data. And so the term that I like to use with interoperability is targeted interoperability. So the physician gets exactly the information they need when they need it. If you give them, for example, an ER doc who has a patient present with chest pains, if you give them 300 pages of a PDF, they will not read it, but they may read some specific targeted information. So I think the challenge is not just allowing the data to flow, but it's allowing the right data to flow at the right time to the right person. And that is going to be a challenge on its own. So structured data is obviously better for the end user rather than just a huge PDF. But interoperability really is going to be the engine to drive, again, consumerism. It's going to be hopefully driving lower costs. It's going to be driving value-based care. Many of the things that are on our top 10 list are going to be driven by data moving freely and not being blocked. And that's a big part of number 10, where it's sort of the external, the policy piece, where the government has stepped up and it is said it is illegal to block data unless you meet one of the 8 exceptions. So I'll open it up to our panelists to talk about A, how important is interoperability, and B, how can we achieve what we really need to achieve?
Eric, you have to deal with interoperability. How do you move data around?
Well, up until the interoperability regs came out, I mean, it was all point-to-point interfaces. And I kind of feel like even though we have a patient access API and we, you know, have put in payer-to-payer and other, you know, API since, I feel like our vendors and our ecosystem isn't there yet, at least in our region. It could be maybe different in other regions, but we just haven't had the adoption of the interoperability services at all in Western New York. This was just very low utilization so far.
I had shared with Charles in a chat earlier that I saw something in the one of the newsletters this morning that just really struck me, and that was that to address interoperability and really to address a number of the issues that we're talking about today, there's legacy thinking, it's kind of legacy cultures that we have to address, but there's also legacy processes and systems and technologies that have to be addressed. I was just responding to Rita and her comment that state by state regulation around whether a provider can actually do a consult when their patient is outside of the state boundaries. Does that constraint make sense in today's world? But on the other hand, when I started thinking about what it's going to take to change that, and that there's been discussion around that for 10 or 15 years. I think my first discussion around telephone consults was back in 2002, so 20 years actually. The ability to make, Rob, what you called in one of our discussions, the data to become the oil for the smooth operations of healthcare, but to do it in a way that the privacy and security is still maintained. That's a big challenge. I don't know, Nancy, if the AMA is, as an organization, I'm not asking you to disclose anything beyond your personal perspectives, but how do we address some of the things, the barriers that Chris laid out to interoperability, to get the data to move and to not have owning the data be the economic pipeline in healthcare, because it really is the patient's data.
Yeah, I think so. I know within the AMA, we've been having some conversations around, where are we at really with interoperability? And our House of Delegates meeting is just wrapping up in Chicago this week. And I believe there was going to be a report for the board or the House of Delegates around, what we see as the status right now with interoperability. I think it's one of those, within the AMA, our physicians go from, single doc practices with, limited or those legacy systems that you're talking about in terms of their systems in place up to, the multi-specialty, with the latest technology, everything that they need. So it's really hard to address this topic in terms of, individual needs. But ultimately, I think it's a matter of where we're at with the technology and then where we're at with the adoption of that technology. So is the technology there to support all of the interaction? And by technology, it's not just the hardware, but the software, the standards, all of that to exchange the data. And then where are we at with having that implemented? And what's the costs around that? And is that something that's viable for a small practice that has the limited resources in order to take on potentially those expenses for that new technology? So and then what is the return on that for them? What situations are they in where they're using that needing that interoperability of the data and using it? So those are some of my high level thoughts around that. Yeah.
So I Ferris, I just want to throw, because something what Nancy was talking about just brought something to mind, which is, over the last, maybe even pre-pandemic, we were seeing this, but the shift of care from the inpatient setting to the outpatient setting has especially been really big for the ambulatory surgical centers, and seeing a lot more care shift to that space, which has brought up, new kind of care pathways. And one of the big things that kind of has gotten disregarded in a lot of that is these surgery centers weren't incentivized or given funding to get EHR systems. And I know for a lot of them, the estimates are, and there's no good count, but something south of 40%, maybe as low as 20% of surgery centers in the country have an EHR system. So you are now sending, and payers are trying to do this, and hospitals are trying to do this as well, as get those patients to these surgery centers where they can get the right-sized care for them. But it's switching, it's taking them out of the EHRs in some cases. It's taking them outside the workflow where you're getting good data, and it's becoming an increasingly important part of taking care of patients, getting the care in the right spot. So when we're talking about the cost and things, we have new things popping up, and surgery centers becoming more involved, but they've never been connected to healthcare in quite the same way. So that's kind of a rising concern as well when we're talking about data availability and keeping that all connected.
Very good point. And I can tell our commitment to the 1 hour discussion could go on for 1 day or 1 week or more than that, and it will go on. We do appreciate the comments and the interactions here, but and there's a lot of different pieces of data and perspectives in Industry Pulse, and both WEDI and HCEG are in discussions about some very specific mini surveys. Charles, I know you and I have talked about really digging deeper into value-based reimbursement and where it connects with all of the different components. But perhaps to wrap up, and then we have a couple of closing comments from each of you who volunteered your hour to be on the panel today. Maybe we start with you, Chris. Any last minute comments from Industry Pulse, and then Eric and Nancy and Rob and Charles, and then I'll wrap up.
Yeah, I think I've gotten more time to talk than anybody, so I'll keep it short. Yeah, I really think even, talking about the data, even though there were a lot of differences between the payer, provider, kind of mass market perspective, I really want to echo the sentiment that I think that there is a shared vision to move into value-based care, to improve payments. I think a lot of us see kind of what the peak is, and we may have different trails that we see to get there, but I know we're moving in the same direction. So I really find that encouraging from this year's Industry Pulse, and I'm excited to see how it progresses this year and future years.
Nancy?
Sure. I think just the comment I was going to make earlier, I was thinking after we were several slides into the presentation, so I'd have to go back and look at it myself, but I would be interested in having Chris go back, or you, Ferris, and look at the issues and then the barriers and categorize them. Is this an internal to an organization, or is it external to the organization? And so understanding a little bit more about where the work needs to happen. Is it kind of a 50-50 split, or is it more on the internal organization to work on, or is it something that is external to them and we need other, they need the external factors to change in order to be successful. So I would be interested in that.
And Nancy, we can go back where we've got 10 other Industry Pulses over the years. Some of these issues haven't changed. We could go back and pull some of that data together and maybe put it out to everyone that's on this discussion where it's of interest. Eric, final highlights? Yeah,
just one final highlight. And I might be biased because I'm the head of a technology function, but I feel like with telehealth and value-based reimbursement, those two topics, we have a lot of technology built around those today. We're not done. I'm sure maybe it's 80% of the way there, but we have a lot of probably cultural and procedural things that need to change. And we've obviously been busy with COVID and other things over the last few years, but I think that's one of the bigger challenges ahead of us.
Excellent. Rob?
Well, I'll show my bias as a policy guy and say that the top 10 list should be reversed. Number 10 on the list is external policy and government. I'd put that number 1. They are going to drive change. Healthcare moves at a glacial pace on its own. The only real change that's going to happen is going to be forced on us. And I think that's going to happen from the government.
Thank you, Robin. I wish we had another hour to have you take us down through the 25 different initiatives that are underway there. I suspect you have a work group, and we all ought to join it.
And
Carlos, any final comments?
Yeah, I think that's a good thing for us to think about, by the way. And then my last comment is, when Chris was showing some of the data in terms of, I'm really excited to see that there is a pathway towards solutions here. And I saw the movement of payers and providers. That was all an encouraging sign that I was really excited about. So I see that as our opportunity to make a difference and continue to figure out those issues that Eric mentioned and Nancy mentioned, and I hope we can do that in future discussions.
Thank you, Charles. Thanks to all of you on the panel and to everybody that's joined in the discussion today. Again, we will, and maybe you can bring up the last slide. There you go, Michael, thank you. There's lots of upcoming opportunities to continue these discussions, and we want to encourage you to do so. But more than anything, my final comment is just an expression of appreciation to WEDI and all of you and your different work groups that have joined in over the last 6 months as we've gone from the HCEG Top 10 to Industry Pulse to this kind of discussion. And my hope and best wish is that all of you and your colleagues will join in the WEDI virtual spotlights coming up. There's a summer forum in Chicago. I believe that's in person, Charles, is it not? And yes. And additional events, you can go to the memberswedi.org event-calendar. HCEG has a number of focus area roundtables where we take just one of these topics and get a small group together to talk about them. And you can go to our website, hceg.org, under events, and see those upcoming activities. And we have newsletters, we have other tools for the industry at large. Please join us. And if any of you are planning on being at AHIP next week, Steve and I will be there. Search us out and we can pick the Industry Pulse discussions back up at that point. Thank you and have a great day.
Thank you, everyone. Bye-bye.